Hi everyone, this is Dr. Fox, and let's talk about the laryngeal membranes and cavities. In this video, we'll discuss the intrinsic laryngeal membranes, their features and how they work. We'll also relate the anatomy of the larynx and surrounding structures to methods of gaining emergency airway access. There are two sets of intrinsic laryngeal membranes. Superiorly, we have paired quadrangular membranes, and inferiorly, we have a single structure known as the conus elasticus. Let's start superiorly or proximally and work our way down. So we'll begin with the quadrangular ligaments. Their role really is to help funnel air into the rest of the respiratory tract. As we look laterally, there are sets or subsets within this. The first one are the aryepiglottic ligaments. Those aryepiglottic ligaments are going to be invested with mucosa and be the aryepiglottic folds, where we can find the cuneiform cartilages. And we can see these on either side, and so you can imagine how they might help affect the shape of the laryngeal inlet. And inferiorly, we have vestibular ligaments. Vestibular ligaments are invested with mucosa, and they're known as vestibular folds, sometimes called ventricular folds. They're perfectly synonymous with one another. You've probably heard of them as false vocal folds. So these aren't the true vocal folds. They sit above them. So between the aryepiglottic ligaments and the vestibular ligaments, these help to shape the proximal cavities of the larynx to help funnel air into the larynx. Now, this is sitting superior to a region known as the laryngeal ventricle. It's this dark area, but we can just fill it in with red. So it goes further laterally than this, so we can only see a little bit of it. But this is going to be space between the vestibular ligament proximally or superiorly and the vocal ligament or vocal folds inferiorly or distally. So those vocal folds are formed from the vocal ligaments being invested with mucosa, and they are of the conus elasticus. The conus elasticus helps to shape and funnel the air as it exits the vocal pathway. So it's air on the way out, specifically for vibrating the vocal ligaments for phonation. There are, in addition to these vocal ligaments, cricothyroid ligaments. We can see the median cricothyroid ligament there, and there are going to be lateral cricothyroid ligaments there and there. Let's put a pin in this median cricothyroid ligament. We're going to see that in the context of an emergency airway later. But what I want us to do for now is focus on the relationship of these vocal folds, so the mucosa over the ligaments, and the vestibular folds. So you can see the vestibular folds are above the vocal folds, and they have a protective function of the vocal folds. The vocal folds are what are vibrating for phonation, but we can also vibrate our vestibular folds as well. You may have heard of throat singing, which is a phenomenon of many indigenous people in Asiatic regions. So with throat singing, you go from vibrating your vocal ligaments to vibrating your vestibular ligaments. And the phenomenon of vocal fry incorporates a little bit of vibration of your vestibular ligaments as well as your vocal ligaments. So all of these are surrounding spaces of the respiratory tract, the most proximal of which in the larynx is the laryngeal vestibule. So the laryngeal vestibule is everything above the vocal ligaments bounded by the epiglottis there and the arytenoid cartilages. So that's going to be on the anterior portion of the laryngeal inlet, all of that space. Then as we move down between the vestibular folds, we have the space between, which is the rima vestibuli. There. Below the rima vestibuli, we have the laryngeal ventricle. There. And then on the other side of the laryngeal ventricle, between the vocal folds, we have the rima glottis, or the rima glottis. That rima glottis is going to be more narrow during phonation and more wide during ventilation. And then below the vocal folds, we have the infraglottic cavity. And then we get down to the level of the trachea. We have the lumen of the trachea and beyond. So let's take a look at how we can gain access to the airway. We were discussing that median cricothyroid ligament earlier, and for emergency access to the airway, we can perform what is known as a cricothyrotomy. The cricothyrotomy is an incision of the skin and the median cricothyroid ligament deep to the skin. This is done under emergent conditions, and it's possible to do so because there are very solid landmarks. So what one would do is we would palpate. So you palpate the anterior neck, and you can find one's laryngeal prominence, and you go inferior from the laryngeal prominence, and you'll find a little divot, and then beyond that, it gets hard again. And so the divot there is where you could perform a cricothyrotomy. You would incise the skin, incise the median cricothyroid ligament, and then cannulate or place a tube through that space in order to maintain an airway. So if there is a proximal obstruction, so something before the larynx, you're able to still maintain an airway. There aren't any vessels in the way, and so this could be done in the field with very simple instruments. A non-emergent procedure, so one that has to be done under sterile conditions, and this is more of a surgical intervention, is that of a tracheotomy or a tracheostomy. And what this is an incision of the skin and then a vertical incision of the trachea. We go about 1 centimeter superior to the jugular notch, and so you can incise right along there. The reason why this must be done surgically is that there are blood vessels that can be in the way. So here we can see the inferior thyroid arteries. Those can be in the way and can be incised during a tracheotomy. And in about 10% of the population, there's a variable artery that's present known as the thyroid ima artery, which would be very problematic if it were incised during a tracheotomy. It would pump out quite a bit of blood. So let's take a look at the larynx and its cavities. We have incised this posteriorly, and we could move this around to see here. We'll look at this slightly askance. Move that back this way. So let me highlight for you. Here are the vestibular folds. There are the vocal folds, just to set boundaries there for us. Superiorly, there is our laryngeal vestibule, vest for short. The space between our ventricular folds is the rima vestibuli. And then this dark space here, that's the ventricle. And then the space between the vocal folds is the rima glottis. And then below the vocal folds, we have the infraglottic cavity. And then below the infraglottic cavity, surrounded by the trachea, is the lumen of the trachea. So we would go from the lumen of the trachea to the infraglottic cavity, to the rima glottis, to the ventricle, to the rima vestibuli, to the laryngeal vestibule, out into the laryngopharynx and regions proximal. So we've discussed the intrinsic laryngeal membranes, their major features and functions. We've also related the anatomy of the larynx and surrounding structures to methods of gaining airway access. I so appreciate your time, and I look forward to talking to you in the next video.